everybody. Welcome to the Center for Health Design's Evidence-Based Design Journal Club. And I think whether you are a risk taker or you're risk averse, today I think you'll enjoy our session on risk assessment. I am Sheila Bosch, and I will be hosting the session today. I'm an assistant professor at the University of Florida, and my research focuses on healthcare design environments. So we love doing these journal clubs, and really the purpose is to engage both researchers and practitioners around this idea of good research in the field and sort of get this discussion going and get the word out about some of these great studies that that have been published. Now, we do offer both EDAC and AIA CEUs. So in order to reach the materials that you need, you'll go to the Show My Media library and click it's up in the toolbar where that arrow is showing. And to download a file, you'll click the green arrow next to the file, and then when you're done, just click the double right arrow in the top left corner of the media library, and that will close, and then the slides will refill your empty space. For EDAC credit, you will need to complete the verification form and then retain it for your records when you need to submit to CASEL Worldwide at the time of your renewal. And for AIA credit, you will complete the verification quiz. You'll also need to purchase a CEU management fee for $10 from the Center for Health Design's store, and then submit your verification form to Shannon Reckline, and she will upload that to your AIA account. And Shannon's email address is located on that form. Just a real quick little review here on how to access the information. So for the chat feature, you'll be able to actually type in your questions as we go along the discussion, and there'll also be time at the end for questions. But go ahead and type those in just as you think of them, and we'll try to work those in. And you just type it right into that chat box on the All tab. So now I have the distinct pleasure of introducing today's author, Patricia Morrill. Patricia has 30 years of experience in healthcare, which spans operation leadership, project management, process improvement, workflow and facility assessments, and lean facility planning. She does hold numerous certifications in project management, EDAC, Lean, Six Sigma Green Belt, and others. Patricia gained a sort of a personal perspective of preventable medical harm by caring for 2 family members, and she has increased her efforts on spreading information about the value of risk assessments and the impact of uncoordinated care in her teaching and publication and national presentations. She also served on the development team for the Center for Health Design's Safety Risk Assessment Toolkit and as faculty for its rollout at the 2015 PDC Summit. So, welcome, Patricia. Thanks for joining us.
Thank you so much. I'm really glad to be here.
Well, I think this is a topic that a lot of people have interest in, the risk assessment, and it's just really important, and I'm excited to get into this discussion with you about it. Today's article is called Risk Assessment as Standard Work in Design, and just what do you mean, Patricia, by as risk assessment as standard work?
Well, standard work in terms of this particular example is facility planning. So that's the work that we're talking about. And standard work typically refers to what are the steps in a process so that everyone can follow the same steps. So what I'm recommending here is that for facility planning, we interject risk assessment as part of that.
Everybody, it just ought to be done, right?
Absolutely, because frankly, in healthcare, what we're dealing with is that preventable harm is the third leading cause of death in the United States. Now, why are we tolerating that? I don't know. So that means we really need to step forward for any of us working in the healthcare industry to do whatever we can to change our processes to help healthcare be safer. And that includes both process and the built environment. So the particular risk assessment I talk about in the article and that I have experience with over 12 years is the failure modes and effects analysis, which is called FMEA. And it is a proactive risk assessment tool and, importantly, a process where the tool helps you with structured conversation. And it was used in the 1940s, I believe. The military, NASA, and then automotive took it on. And then Six Sigma uses it because you look at reducing errors and failure.
Mm-hmm. Yeah, I know that you mentioned in your article St. Joseph's Weston, the first hospital designed specifically around patient safety, and Gresham Smith and Partners designed that, and I know they used a lot of FMEA in that process as well. So we're going to look specifically at a couple of cases that you've worked on, and so do you have anything else to add? I know we talked about how the preventable harm is the third leading cause. Is there anything else regarding risk assessment you want to share?
Sure, and I think design brings out people's passion. Everybody has a priority to focus on and what's more important to some people. And so what we need to do is to start challenging opinions, because a lot of people are passionate about a particular opinion they have. Something has to be done a certain way in healthcare design. We've got to start challenging that because we need to innovate and do things differently. So that's why a risk assessment brings much more rigor to decision making and challenge those opinions.
Yeah, way too often I think it's the domineering voice that wins if you don't do something like this.
That's right.
Oh, so tell us a little bit about these two cases that you wrote about in your paper.
Sure. What I looked at was two different hospitals in terms of their case study. And the first one, Hospital A, was a critical access hospital. A very frequent, I find, question that goes on with really small hospitals where they only have about 2 to 6 ICU rooms. Where do you put them? So the question that was faced was, fortunately, during design, where should ICU go? And we had very strong opinions, even from the COO of the hospital, saying absolutely it needs to be near the emergency department. And because we had differing opinions, and because they were struggling in their current state with ICU staff feeling isolated from where they were, I asked if we could do a risk assessment to try to truly understand what a safer and to be proactive about risk management. So we did the FMEA and looked at the specific question, because you do need to drill down with FMEA to come up with a very specific question that you're trying to deal with. So we looked at, should the ICU be adjacent to the emergency department, or should it be adjacent to medical surge? And then with the second hospital, they were a rural hospital with about 50 beds. It was a phased replacement campus, and that's really what created an issue. We were in the middle of occupancy planning, and I was teaching a lean process problem-solving workshop, and the problem they just were stuck on was with this new construction, the surgery now would be located pretty far away from the existing lab until the lab could later be moved. So what the big deal is with frozen specimen is that a patient is sedated and under general anesthesia in the operating room, and they are waiting for the results from the lab of what the sample taken was. So typically 10 to 20 minutes is the most that you want the patient to be asleep waiting for these results from the lab. So that's why it becomes an issue.
Okay. Well, so you used some very interesting methods here in this study. So just talk to us a little bit about how you conduct these risk assessments in these cases.
Sure, and as I quoted here from the EDAC study guide, just-in-time research, FMEA is a wonderful tool to use for just-in-time research, which helps you quickly with our design projects. Everything has to go so fast, and decisions need to be made quickly. So the FMEA process is very helpful in coming up with what a good solution should be. The answer tends to unfold and to come up with that best solution so that it's not just somebody's opinion.
Mm-hmm. Now here's an example, and it might be a little hard for our viewers to see, but this is the actual tool, like the data collection, sort of a information gathering tool that you use, correct?
That's right. So basically what the FMEA looks at is failures. So how can you prevent a failure from happening? And with the tool, you look at the potential failure that might occur and what would be the effect. So if it happened, if this happened, what would be the effect? And then you look at what are some potential causes for it to happen, and then do you have controls in place that you might be able to detect it? And then in a moment, I'll talk about the actual measurement and the rigor that comes along with that. To the right here, the last column is recommended actions. So what could you put into place to try to prevent something from happening? What's not on the slide that continues on to the right is you actually rescore it. So after you put forth your recommendation in place, you come back to this to see did it in fact help, and you have a better situation.
Now, I would imagine you're looking, not when these recommendations, the recommended actions, you're not just looking at the design piece, right? You're looking at process changes and improvements that could be made as well. Is that right?
Thank you. What's wonderful about the process of the FMEA is it brings together a more holistic approach, looking at workflow, process, patient flow, and how it integrates with the built environment. So that is the wonderful component, because you're looking at a particular element and what could happen. And what can happen is anything in terms of space, falls, or process with medication errors or whatever it is.
Mm-hmm. Okay.
Then here, this talks about what actually occurs during the FMEA process. Typically, it takes about 2 to 2.5 hours, because usually you do just-in-time training. What is the FMEA tool? And that occurs in the beginning. And then you have to have a multidisciplinary team that really understands what's at hand. But you also want to have somebody present who knows nothing about it, so that they can ask questions without having preconceived notions about what the process actually is. And then I really like to have administration there so that they can help quickly make decisions and say, yes, let's go forward with this or not. And then, so the process itself, again, you drill down, so you have to be pretty specific in terms of what you're looking at. So the first thing you want to do is to flow the process from a very high level. And then if you have a floor plan, to show that and use what that flow would be for patients, staff, or whatever, and you may not, because hopefully you're doing this early enough and pre-designed that you may not even have a floor plan yet. Then from your flow, you start to identify where might the greatest areas of risk be. And so as part of your flow process, you may end up with 1 or 10 different FMEAs because you identify several different areas of risk that you want to look at. So by doing this, flowing the process, talking about the particular areas of risk, it pulls everybody together on the same level. So a lot of times nobody understands the FMEA process. So now we're on equal footing. So whether you're a director of facilities or you're a nurse, we're all here learning together. And so it's a great process that way.
So so you have the initial 2 to 2.5 hour session. You do the training. If you do identify 10 different sort of processes that you're going to look at, then how does that work? What's next?
Well, typically if you're dealing with a particular process flow, then you're working with the same people. Different failures you're trying to prevent, but they go much quicker then because they've learned, they understand the process. So then your follow-up sessions may only take 1 hour. And you might bring in some other people as well, but they tend to go really fast once people understand what the process is.
Mm-hmm. I'd say that's true about all sorts of things.
Yes. And
so you did mention a little bit that, risk is really sort of this combination of, how severe is it if it happens, what's the likelihood it would occur, and then, are there controls in place? So how do you then come up with sort of a quantified measure of risk?
Well, what's important is that the scale to the right of the slide, typically it's 1 through 10. So you want to make sure that every single number has a metric assigned to it and that everyone understands the scale. So you're going to score 1 through 10 in terms of severity. How severe is it if it happens? Is it a 10? Somebody might die. Is it a 1? It's inconvenient. So what can you do to define each number so everybody is using the same scale? And then for the likelihood, you're going to have a different 1 through 10 in terms of scale and detection as well. So for example, you want very clear metrics. So you might say, how likely is it that this will occur? So a 1 could be, it's pretty rare. An 8 could be that it happens 4 times a month. A 4 could be it happens 4 times a year. So that way, everybody truly is using the same system. They're not just subjectively saying, oh, it feels like an 8. So that's one thing you want to be sure about. And then you multiply each of these numbers. How severe is it? If it's a 10, occurrence. If it's a 4, detection. If it's a 2, and then what is that total score? Typically, if something did score a 9 or a 10 for severity, even if the overall score ends up pretty low, you still want to address it, because if it's something that could be pretty severe, you want to address it anyway.
That makes a lot of sense.
Yes.
So how do you go about then actually collecting this data? I mean, you have the multidisciplinary group in the session, and then sort of what else goes on?
Well, you want to understand who might be missing in the room. If you can't do the flow to begin with, you need to stop and either go observe or go get the right people, reschedule, because if you can't do the flow, that means people in the room truly do not understand the process. So that's the first critical step. And you might want to go forward and say, for the next part of an FMEA that we're going to do, we need to add somebody else. So you have to be mindful about that. Then after the session, you want to be sure to add your recommendations and then go and pilot and trial those recommendations. Now, sometimes if it truly is a space issue, we may not be able to try it until they physically move in and occupy the space. However, I do encourage people to try in mock-ups or to take their existing space and make whatever modifications they possibly can to try something so that we still have time to correct it before they truly occupy. So, and again, if you identify a risk, you do want to try to do something as soon as you can to help prevent any issue around that. So after you try your recommendations, you come back, you rescore. How did you do? Did it improve? Terrific. If it didn't, then you want to try some other elements. You want to keep hammering away till you can truly see that it's made a difference for you.
I think it's impossible really to overstate the usefulness of mock-ups.
Right. Oh, no kidding.
It seems like it's always worth the effort and the cost involved. So what did you find during these two examples? You told us what the problems were. So what were the solutions? Well,
just like my history has shown me over the last 12 years, it's just amazing how the best decision unfolds. So in the ICU situation, the chief operating officer, who really insisted that it be located next to the emergency department, was in the room during the FMEA, and she just said, oh, okay, fine. Clearly, it's a much better thing for it to be by med-surg, because what they found in terms of their conversations and doing the flows, they realized that ICU and med-surg were much more similar in terms of care for patient. And the hospital usage, the supplies, the medications, technologies. So it just became very clear. So that was extremely helpful. And so therefore we made a prompt decision so the design team could keep going and now knew how to design that space. With the second one for the specimen transport, what was interesting is when you do the flow and you start realizing, wait a minute, what I thought was the highest risk really isn't. So here they were so concerned with, the pathway, the containers to transport, when the number one risk was the alert system. So no matter how fast you can get it to the lab, is the lab staff going to know that there is an urgent stat specimen there that had to be handled while the patient was in the OR at the time? So the alert became the greatest risk, and then they continued to work on the transport as well. So it does help you prioritize to understand what the greatest risk is to address those.
Now, for Hospital A, I know you said that it was better to locate the ICU next to med-surg, but you wouldn't say that would be true of all small hospitals, right, with a small number of ICUs. I mean, is every case is individual, or can you sort of say, yeah, pretty much if it's a small hospital, maybe it should be located by med-surg? What do you think?
I think that hopefully the article will help some hospitals who struggle with this question and show them that how they can do their own FMEA to come up with their answer. So I don't think it's cookie cutter. I think that's why we all keep doing project after project, because they're all different. And the demographics are different. What you're dealing with is very different. So it's definitely not the right solution for everyone, but I do see a lot of hospitals question with this. So hopefully they see this as a good process they could use.
We've had a couple of questions come in, and one, you've talked about detection, right? That one of those three elements of risk that you score. And so I think someone would like to have a little bit more information about what you mean by that detection piece. And like, so is 1 or 10, like what would that correlate with in that category, perhaps?
Sure. So the score of 1 would mean very low, that you have controls in place that it would be extremely obvious if something went wrong. So a lot of times we say, well, we have preventive maintenance. So our preventive maintenance can help in terms of looking and making sure that things are in good repair. What comes with detection also, though, is it retrospective or prospective? So we would understand after the fact as opposed to it would become so clearly obvious to us. So that's what it's really looking at, controls. So what's in place that would help be a red flag that there's an issue and that you could quickly deal with it.
So a lower number is better.
Definitely.
Okay.
Definitely.
There's another question, too, wanting to know whether or not the team did explore sort of the rationale that the administration had about wanting to locate the ICU rooms near the ED, and they're curious as to sort of what was the thinking behind that? Like, why would you typically want to include the ICU by the ED?
Sure. And keep in mind, critical access is a maximum of 25 beds. So the 25 beds would be ICU, med-surg, OB, whatever your acuities and your patient levels require. So sometimes, because it's such a small hospital and you have so few staff, sometimes the question is, if I only have 2 ICU beds, maybe the emergency nurses are better trained and better able to deal with ICU critical care patients. So that's sometimes what people think, but then truly when you think about it, in a critical care hospital, you're usually there to stabilize and transport them somewhere else. So your ICU patients are typically don't have the high acuity that you might see, clearly in a trauma hospital. You want to quickly stabilize and get them moved out. So, in fact, the smaller hospitals are finding that cross-training ICU and med-surg nurses to go between those 2 units because, again, the care is a little more similar. But the reason that the COO thought that maybe ICU and emergency, it was a nursing staffing issue in terms of ability to handle the type of patients.
And the final solution in Hospital A, did they made those rooms acuity adaptable, is that correct?
Yes, I actually have a slide just a little bit that.
We will get to that shortly.
So truly, in terms of what happened is in both of these particular hospitals, by using the FMEA, we were able to have more informed decision-making, which is really what I'm asking designers to think about, to put more rigor into that rather than opinions. Because if we had just listened to the COO, okay, that's what we would have designed and that's what would have happened. So was that really the right thing to do, the safest thing to do? And we came up with a different solution. So, and again, in both cases, it was so helpful to talk through the process as well as the space And so we understood the impact of both of those.
And I would say a lot of clients, they appreciate a little bit of pushback or a little more questioning from the design team, because they know that you've designed, a whole lot of hospital or clinic spaces. And so, I think most of the time they're okay with you saying, let's take a closer look at that. Now, sometimes obviously have very strong opinions, but
exactly. And how many people truly, when the way I approach it is, the people around the table are very smart people, highly educated people, designers and hospital owners. And so when there's a differing opinion or we're just not sure, then when I say, can we do a risk assessment on that, who can really feel like they could say, well, no. So it's a nice way to broach the subject. Since we have differing opinions, can we go through this process? And what was delightful, actually during Hospital A, we also focused on the OB unit and ended up doing about 10 FMEAs on that unit. And then over time, it was wonderful for people to come to me from the design team, from the nurses, and say, I think we need to do an FMEA on that because I'm not sure. So that, you're in the right direction.
They really see the value, obviously. So who typically would do this kind of a risk assessment or go through that FMEA process?
Well, in the early 2000s, Joint Commission required hospitals to do FMEA. Why they stopped, I don't know, but they did. And so early on, nurses and others in the hospital knew how to do them. Since they may not be doing them anymore, you find consultants or the quality people in the hospital may know how to do it, or consultants like myself who are trained in Six Sigma can be part of the design team and help do this process.
Okay.
So
here's a little more.
Yeah. Here's the floor plan that shows the final design for the ICU and the results and how it ended up. Because in their current situation they felt isolated, which did not feel safe to them from a staffing perspective. So here we were able to, the orange shows the ICU placement and the flow for that, and then the green is the med surge. And so they had 2 ICU beds, but then they created an acuity adaptable room so that ICU could float into the acuity adaptable to have 3 rooms if they needed it, and then became quite valuable for med surge because they could float into that room if they needed it instead, according to the census. And so we had decentralized nurse stations, so that way they weren't too far away from each other at all if either of them needed assistance.
Oh, that's great. So what if, so we don't have a similar slide for Hospital B. Okay, so I know what a lot of our participants are really interested in are, so now what? What does that mean for us as researchers or designers in the field? So just share a little bit about that.
Well, I think that this is an excellent way to do research. Just-in-time research is how this is qualified. And as I said before, if there's an unclear situation and people are not sure of the best design solution, then it helps you with informed decision making, so that you're challenging those opinions by letting the conversation, it's a structured conversation, that's what's important, to come forward with the best solution. And this is a way to show more rigor. Again, we have got to do things differently. We've got to be more innovative. We'd have to challenge each other because preventable harm is the third leading cause of death in the United States. I have to say that again because we need to take this to heart, and risk assessments are an excellent way to help do things differently and come up with those innovative ideas. The best time to use it is pre-design, when you're thinking through how you want, from a steering committee, high-level perspective, what it is that they're currently struggling with in that particular hospital or clinic as well, and how can we best address those issues for the future for them. However, any issues that come up through design, occupancy planning, even construction, if something comes forth, it's time to do a risk assessment at any time. And the great thing about this is FMEA can be used in conjunction with the Center for Health Design's Safety Risk Assessment Toolkit. So I hope that designers and architects are learning about the Safety Risk Assessment Toolkit. It is excellent that the facility guidelines is requiring, for very good reason. It was interesting that when I published this article, I had no idea about the facility guidelines, so I was very excited with that. So your Safety Risk Assessment Toolkit, as you go through that process, you may find a particular risk that you want to delve into deeper, and that's when you would go and do an FMEA to do further analysis on that. So they really work together hand in hand.
The center's tool, wow, lots and lots of time and effort went into the development of that. That's where I first met you, was on working on that advisory group. So, but yes, if folks haven't seen that, I really strongly encourage you to go to the center's new website and check that out. Is there anything about this particular slide you wanted to say, Patricia?
I think this is the slide we wanted to highlight from the Center for Health Design's website on how you can access the Safety Risk Assessment toolkit directly from the Center for Health Design website.
Mm-hmm. So it's under Insights and Solutions, and then you'll see the Safety Risk Assessment. And there is an Excel version available to you, so I really do encourage you folks to check that out. So, of course, every kind of research has limitations, and we just state what those are. So what are some of the limitations with the studies that you've conducted?
Well, clearly with any FMEA that you do, the values in the structured conversation. So what that means is who's in the room is of utmost importance. So you have to have a multidisciplinary team in order to have a more robust conversation. And so it could very well be if we had had different people in the room, if we had only had nurses, only had certain people in there, if I'd only listened to the administrator, then the solutions may have been very different. So the people in the room are what is critical to this, and then the facilitator. So the facilitator does not need to be a subject matter expert. So clearly I did not know all the detail about a frozen section coming from the OR to the lab. I learned a lot, and some things I didn't really want to know all about, but you have the nurses and those talking about it. So as facilitator, you ask the questions, you help guide people to stay on track, to follow the structure that the tool brings forth. So you do need to be trained in FMEA, and you do need to be an excellent facilitator, but you don't have to know the actual content that's going to be discussed. So again, if a consultant or someone trained in FMEA would be necessary.
Okay. Well, I'd like to just encourage folks to send in your questions. We've had a couple, but we'd like to have more. So just go into that chat box there and type your questions. Do this on the All tab. And we'll just give it another couple of seconds here and let people's fingers get to work and see what else we can answer. Pause. Awkward pause for a moment. Well, maybe you've covered it so well that there aren't additional questions. Here comes one. So this question is, were both of these projects part of a lean process improvement project or not?
Actually, the first one, the ICU, was not. And the second one, in terms of specimen transport, came out of, I was teaching lean problem solving. And so the issue came out of the problem solving, and they were stuck on how to resolve that. So that's when I asked if we could do a risk assessment to try to resolve the problem. So that one did. We were in occupancy planning at the time. So fortunately, we were able to work through those solutions about 5 months, I believe it was, before they actually moved in. So we were able to catch that in time.
You know, and one thing I love about what you were able to do is you didn't just, suggest these things on the front end. You actually went back after they had occupied and tried to find out how did that work, right? So tell us a little bit more about that follow-up.
Right. Well, it happens that for the first one with ICU, the plans that I showed, I'm in the middle of post-occupancy evaluation now. So they've been open for a year now, and we are testing the various components. So we were glad to hear that this has been a wonderful solution for them, and the work that we did on OB as well. So they definitely found the benefits from that. And the specimen transport, they were able to work through the alert system, and at the time, pneumatic tube was new for them, so because of the distance, they couldn't just be walking the specimens all the time, so they had to go to pneumatic tube, but also the alert system with that tube system. So how do we work out a new process and understand from a facility perspective with the tube system that everything is working together because of the quick time frame that's needed. So they, I think they've been in about 18 months now, so we were able to look at those, the success of that as well for them.
So do you have any idea about, what percentage of projects, healthcare projects in design, actually use currently an FMEA or some other kind of risk assessment process? Is it pretty small still?
It's pretty small, very frustrating, certainly not as many as I would like. So, some people feel that they have their risk assessments because clearly in healthcare there's all kinds of assessments that have to be done. So, again, people come with preconceived notions. They know how they want it done. So you really have to work with the executives on the design team and the hospital to ask them to look at a situation. And I do use research to show why, again, citing quality issues and bring forth some best practice from other places. Here's some other ideas. Let's do an FMEA to see if this kind of best practice would work for you or not. So trying to educate people that others are doing things a different way, or what the quality measures are that things have to be innovated in a much better way. So people get kind of excited when you talk about trying to brainstorm and think about different ways. Because again, we all come with our passion about design, and when you put people in the room together, they have all different ideas of what they're excited about. So when you talk about patient safety, that tends to get people to listen in a different way. So if we could use more rigor in our decision making, that, again, people can't say no to that as easily. So I'm hoping that with both this article and with the Center for Health Design's exposure with the Safety Risk Assessment Toolkit, I'm really hoping we'll get to go further with that. Because Joint Commission was involved in the development of the toolkit. So that's also one thing I'm telling the hospitals now. If Joint Commission's involved, whether they require it or not, they're going to think highly if you use it for your decision making.
There was a good question on, we talked about you going back and following up, post-occupancy. And the question was, who funded that post-occupancy piece, or is that just something you did on your own?
Well, actually, I'm in the middle of it right now. I did 6 months, and now I'm doing 12 months. And so expenses are reimbursed, but my time, because I wanted so much to do it, I'm actually donating my time. Not what I want to do in the future, but
right.
For this particular small hospital, I felt it was important to, because we did so many FMEAs there, I really wanted to find those results, and they've agreed to do a research paper to publish. So
good.
Hopefully, maybe I'll come back and be able to highlight that.
Well, we appreciate your dedication to the process and to the follow-up as well. We did have another question, too, that seems to be the perception that FMEA is used more for hospital replacement. Is that true or not? And then for a brand new project in a new site, can it also be, usually used in a replacement, can it be used in a brand new hospital, in a brand new site?
Well, if FMEA came from the military, came from NASA, and frankly, when I first used FMEA about 12 years ago, I was working on a project that I felt was very high risk. It was a 500-bed replacement hospital. We were demolishing buildings and building new buildings right next to patient care. So when I was trained in FMEA by American Society for Quality, it was their first incidence with it being used for construction. So that's how I first used it, was actually the construction project itself in terms of minimizing risk to our patient care business. But FMEA, when Joint Commission required it, it was more for medication errors. So it had nothing to do with building projects at all. So FMEA truly, and I think originally, didn't really have anything to do with design and construction. So, but it has been used more and more over the last decade for those purposes. So FMEA can be used anytime on a process that has nothing to do with a space project or related to projects. So it just so happened that for the HERD journal, what I submitted was 2 design projects.
Mm-hmm. Okay. See if we have any more questions. I don't see any other ones coming in. I just I just wanted to, first of all, thank you so much, Patricia, for sharing this with us. You've been a great guest author, and I appreciate it.
Thank you.
I'd just like to remind all of our participants that if you want to get CEUs for this session, download the form from the media library. For the AIA, you'll need to purchase a CEU management fee, complete the CEU verification form and quiz, and email that to Shannon Reckline. And I just want you all to save the date for our next EBD Journal Club. That will be on June 1st at 1 o'clock Eastern. And I'll be having a discussion with Rose Gunn on how design can impact the integration of behavioral health and primary care. So hope you can all join us for that. This event is brought to you by the Center for Health Design, and thanks so much to the Herd Journal for providing free access to the articles to registrants for these sessions. If you have not already done so, we do recommend that you would subscribe to the Herd Journal. And we'd like to give a special thanks to today's thought leadership partner, Karstens. So thank you very much, Karstens. This concludes our event. Thanks again, everyone, and I hope you have a great day.